same as it was for all-cause mortality. And you may perhaps understand why treating prostate cancer can reduce your all-cause mortality, but it's harder to understand why it would reduce your non-cancer related mortality. And then look at the graph here. Observation alone, radiation therapy compared to non-cancer cases. You can see observation is not great. Radiation will give you an outcome between having cancer and being observed or never having cancer. But there's a warning sign if you look carefully at the graph. And that warning sign is that the curves actually cross. And that's hard to explain, huh? And look what happens if we take radical prostatectomy in here. Then you'll do better than if you never ever had prostate cancer, huh? And that's something for the gentlemen in the audience to consider. Why not have a prophylactic prostatectomy? Because you will live longer than if you never had cancer or were treated for cancer. And that, of course, shows that it's selection and not causation, huh? And that's the bias. These individuals are biased. And despite correcting for all these covariates, it's virtually impossible to adjust for that bias. And that brings us back to the starting point. It'll be a good while before we get rid of the randomized controlled trials. So the next speaker is Quinn. And we'll return to the questions later on. So you will have a chance also to comment if you are in deep disagreement with what I just said.
You're expecting me to remember my question.
Of course. You're on the panel, so you should remember.
No, not at all.
Okay, thank you so much for the invitation to be on this panel. My talk is also going to be about big data. I'm going to give examples more from a non-clinical viewpoint. So the first example is youth interaction. So we were interested in treatment heterogeneity because treatment heterogeneity can tell us, for instance, what subgroups may have experienced different effects. So in randomized trials, we look at the main effect, so the effect of the treatment on the whole population. But sometimes we're also interested in seeing whether certain subgroups experience more beneficial effects than the main group, or some groups may have actually experienced detrimental effects. So I think the next question is why big data? Because we can do this already now with our traditional regression methods. So big data can be applied in this setting in that, for instance, in this paper, we looked at 35 potential effect modifiers. And if you, traditionally in regression, you would add them as interaction terms. So for instance, 36 interaction terms, variables interacted with treatment, and then 35 combinations, and then 34, and so on. But then if you counted all the combinations that you would need, it's actually in the billions for just 36 variables. So in that way, traditional regression methods, you can't necessarily find all the interactions that you're interested in because that would involve testing so many possibilities. So one way big data techniques can be leveraged is to do more of an exploratory analysis. So this software is already, this package is already available in R. It's called recursive partitioning, and you put in variables that you think are effect modifiers, and these could be drawn from theory, so it's not purely empirical, but then from theory and from the literature and from your past work. So you identify effect modifiers that you think might modify the effect of your treatment, and then the model splits your data and keeps splitting it until it identifies homogeneous groups that experience relatively similar treatment effects. So we applied this data to one experiment, housing mobility experiment. And for this housing mobility experiment, they moved low-income families from high-poverty public housing to lower poverty private housing. And there were the groups that experienced beneficial effects, particularly beneficial effects for adolescents who did not have learning problems, whose household was not victimized by violent crime, and whose households moved for better schools. The youth who experienced detrimental effects on behavior problems, this is one of the outcomes, were adolescents who were greater than 10 years old without learning problems, whose households was victimized by violent crime, whose partners did not merit and who lived in an unsafe neighborhood at baseline. So this kind of modeling technique can identify higher order interactions and groups of characteristics that you wouldn't necessarily hypothesize in the beginning. So this is like one way to apply a big data technique to traditional research question. So the next example is using Twitter data or social media data to try to capture characteristics at the area level and to see whether those characteristics are related to health outcomes. So our group is collecting Twitter data. For this study, we collected Twitter data over the 2015-2016 year. And for this analysis, we summarized at the county level and then looked at county level health outcomes. And this is looking at 3 characteristics: happiness, food mentions, and physical activity mentions. So we found that communities or counties that had more happy tweets, that tweeted more about physical activity, that tweeted more about food, had substantially lower premature mortality, which is death before age 75. So this is kind of one way of using social media data to characterize social environment characteristics for the whole US and not just for one area. Because if you were going to do a health survey, this would be very expensive to do. And so social media and other big data sources can be used to collect that sort of data. And the latest, third example is using Google Street View. So we are all familiar with Google Maps. And then Google Street View is just when you can view the street level pictures that are associated with certain locations. In our pilot study, we collected data for 3 cities: Chicago, Salt Lake, and West Virginia. Here I just present Chicago, but we're using these images to build environment indicators, so neighborhood environment indicators, and seeing whether those are predictive of health outcomes. So in our Twitter research, we are using Twitter to characterize social environments, but for Google Street View images, we're using that to characterize built environment characteristics. So walkability, green space, building types, the graffiti, trash, those kinds of characteristics. And for this, I think there were over 200,000 images for Chicago. So we collected street images from all intersections in Chicago, as well as a random sample of street segments 50 meters apart. So you couldn't really do this by hand. So we used computer vision to process this, and the computer vision models were trained on manual annotated images, and they performed pretty well. The agreement between manual labels and the computer vision models was 85% to 93%. So they agreed pretty well with these simple indicators of the built environment. So that's also one way to advance neighborhood research.
Hi, I'm Ed Sondick. Just a bit of background. I used to head the National Center for Health Statistics, which is down the street and around the corner here. And I was also at the National Cancer Institute. And recently I've been working on Healthy People, okay, which is really a range of data from national data down to the community level. So the question here, do data matter? Do they inform personal and community decision-making? My answer to that is sort of definitive, not necessarily, okay, based on all that. These are the questions that I submitted. I have only 4 minutes. I have 40 slides, so I'm going to move quickly.
I noticed that.
Is there a community data shortage? So just for fun, this is the truth. I looked at a map of the US and I just went like this and pointed someplace. And I got Wabaunsee County in Kansas, sort of in the center of the country, about 100 miles from Topeka. And I said, I wonder what data they have in Wabaunsee. The population is 7,000. The largest city is Alma, which is 700 in that. So I said, well, what do they have? Well, it turns out from the CDC site, and I guess the writing is a little small, I'm sorry, but this is on the web. You can take a look and look at all the different community data sources or related data sources that there are. The county health rankings, which I'll come to in just a second, the behavioral risk factor surveillance system, which many of you no doubt No, there's the vital statistics collected by NCHS, which is local as you can get. It's births and deaths for the entire country. And so and then there's healthy people, which I'll talk about in a second too. So there's a lot of data, and a good deal of this data deals with Wabamsi, including the county health rankings. But let me talk about the healthy people first. Healthy People covers the country in a set of objectives, 1,300 objectives for Healthy People 2020. The next round that we're working on, advising the department on, may have many fewer than that, but we really don't know at this point. A lot of different topics, okay? And the data is as local as you can find data sources for it. So where you can use the behavioral risk factor surveillance system, it's quite local or quite community oriented. And it may be something else like nutrition, if that comes from the NHANES survey, also conducted down the street, then it's not local at all, but it may be pretty good from a racial and ethnic point of view. So the point of, and this shows what a typical objective looks like in Healthy People with data and a target. So the question is, can we find data for all of the objectives that we have? Now, one thing that I am really impressed with is the county health rankings. It says country health rankings because that's how I type, but it's really county health rankings. And this is really terrific. It's become very user-friendly. And if you've never gone to the website and looked at their website and looked at it, it's just so easy to go in and look up Wabamsi. And lo and behold, there is data for Wabamsi. And where they didn't have actual data collected for Wabamsi, they made it up. Now, what they did was they estimated it. They modeled, okay? And they have some very good, rigorous estimates for it, but they're very clear on the website that they're estimates, and you really don't know whether you can compare this year with last year or whatever. So this is very helpful to Wabamsi. But what I think of is Mr. Jones in Wabamsi, who wants to figure out a treatment for his health problem. Okay? Where does he go for that? Okay? And he also wants to know how good that treatment will be. And think about the county planner for Wabamsi. Even though there are only 7,000 people, that person's problems are very similar to health planners for everywhere. So you might think, and given these three slides, there is all the data that one would want. But one of the national committees, the National Committee on Vital and Health Statistics, said it is not enough, has created a framework, and has commissioned an outside organization, volunteer organization, to develop a set of measures. And currently there must be 1,000 measures that are being sorted through. And the question is, will they be there for Wabamsi? One thing I think of in answering the question is about do data matter, is the issues, the local issues, and how they're going to be answered with the data. And I get very concerned about data, because data alone are a bunch of numbers. If you're lucky, they've been transformed, as it says on this slide, and many of you have seen this kind of thing before, in information. And then after that, you integrate that together into knowledge and understanding, and if you're lucky, you get wisdom. But without the requisite support, data don't matter much. Okay? And so what do you do if you live in a community that has so little resources? I checked on colleges. The colleges that are available are technical colleges. Okay? The nearest university that would do the kind of research on data that we just heard about is in Missouri, okay? 300 miles away. But there are resources that can be brought to the community. So does it matter? It does matter, in my view, but it's only going to matter if you have the requisite other resources that go with it. Okay, thank you. Sorry, and I still want to ask my question.
Okay, I'm Luisa Franzini, and I will be talking about the use of data in health policy. And I will be giving you some examples where data have been used in making policy, and some examples where, despite the availability of data, policy went the other direction. So the first example I want to talk about is a study that we at the University of Maryland School of Public Health recently completed, which was commissioned by the MHCC. And that started actually with a policy. In Kent County in Maryland, there is one hospital, and that hospital was supposed to be closed, but the residents were very upset about that. And so they organized and eventually went to the legislature, which passed the bill, Senate Bill 707, which called for stopping the closure of the hospital and instead recommended that a study be done to find out what is healthcare like in the Midshore area and what should we do about it. So we at the School of Public Health were part of a team that collected data to answer that question. And we collected different kind of data. Some were qualitative data through focus groups and interviews, and some were data which were already existing. And I'm giving you an example here in this slide. This is based on claims data for patients who are privately insured in the all-payer column, who were on Medicare or on Medicaid. And then we looked at the different type of care that they received: ambulatory care visits, inpatient visits, and ER visits. And what the question we were trying to answer is, where do patients go for care? So do they stay in the region? Do they stay in state? Do they go out of state? And that was important to find out, where do they go for care and what kind of resources do they need. So in this particular case, we used a lot of data. So if you look at the line level, when you go to claims data and you go to the line level, each claim has many lines. We are talking about hundreds of millions of data there, which were aggregated to provide this kind of information. And I'm pleased to say that we made some recommendations which were put forward to the legislature and were taken up by the legislature. They were passed in the Senate. I believe the House is still reviewing them, but we hope that that will actually eventually end up in legislature that addresses some of the healthcare issue on the Midshore. And so the recommendation that we put forward based on the data are having an impact. Okay, second example is again, a policy. Well, this is not directly a policy, but the state of Texas came to us and wanted to know how to reduce cost in Medicaid. Medicaid is one of the largest budget items for many states, and neonatal intensive care is a big chunk of the Medicaid spending. So they wanted to know what can we do to reduce that spending. So what we looked at, again, we used claims data, in this case Medicaid claims data, and looked at variation. So first we created these regions that you see on the maps, which are basically market, hospital service area or market for NICUs. And then we looked at those which were high spending versus low spending, and was the spending due to price or to utilization. And then we look more into detail, what type of utilization and why are there differences and why are there differences in prices. And again, because we are contracted by the state, we assume that there will be changes made and it will have an impact, a policy impact. So that's another example where data are impacting policy. My last example is a study that I did a long time ago, 2004, when that was also in Texas. A law was proposed or was going to be implemented, where basically every provider that saw a teen where they had sex had to report to the state, and so that would be that was going to be a criminal offense, and so that of course had a lot of repercussions. It completely flooded the police, and teenagers wouldn't go to the doctor anymore because of the doctor would tell their parents and so on. So anyway, we did a study and we showed that this law had an impact in that it was going to cost the state over $43 million, right? And so that was published, and there was a lot of debate about it. But the one thing I want to share with you is that when this came out in the press, a lot of readers wrote letters commenting on it, and one reader in particular wrote, "I don't care if the state has to pay $43 million, but I want to be able to control what my daughter does." So I just wanted to share this different experiences of how data are used in policy, and I look forward to our discussion later on.
Smiling to myself because when I proposed this title, I didn't really have any idea that people would be actually agreeing with me about this title of, the data matters, and sometimes they do, and sometimes they can lead you astray. So my career has been, since the very beginning, looking at how treatment decisions or treatment decisions made by policies, which really in fact are not personal decisions, how they're made and the impact that they have on people's quality of lives and their health outcomes. And the first study I ever did as a graduate student had to do with the Short-Doyle Act, when mental health patients were released into community boarding houses and left there, and some went home, but not very many. The one I'm working on now, my work has kind of evolved, and the one we're working on now to get off the field, probably this week, is looking at the new data on colorectal cancer rates among younger people. And we're looking to see if people who are older millennials or younger Gen Xers can distinguish between true and false data on their risk. So this is kind of an interesting, kind of different flavor for me, but still very important because our screening law is now not picking up on the rates that younger people actually need screening. I'm going to show you some very simple data though, because I want to make one simple point. And that's looking at some data that my team and I collected in Florida from about 1,850 colorectal cancer colonoscopy patients. And these data were collected kind of shamelessly right before they went in for their colonoscopies. I know it seems intrusive, but people were really good sports about it. I don't think I would be, because, you don't feel real good right then. So I want to just present three questions that were in those data and look at just the simple one-way ANOVA from looking at 4 different characteristics, patient characteristics. So this question was asked within the context of colorectal cancer and what would people do if they had it. I would gather as much information as I could before deciding on treatment. So these are people who are saying that they would use data, okay? So we looked at that by perceived health literacy, race, age, and income. And if someone said high on this, they're actually disagreeing with it. So it's kind of a backward scale. So the people at risk for not wanting to use the data, statistically at risk, would be people who perceive their health literacy to be low and people who are in the lowest category of income. Okay, they have no preference for using data. The next question is, I would rather have my doctor make decisions than to give me a whole lot of choices. Okay, so they're looking there, doctor versus choices. Here, the star categories are the ones that are at risk. So low perceived health literacy, being Black, and again, the lowest income level. The final question that I want to present is, the important medical decisions should be made by my doctor. So these are people who really feel they want to turn their lives over to the doctor. And here at risk is someone in every group, people with low health literacy, perceived low health literacy, Black race, oldest age, and that should be the 75 plus, really, that's over there, and low income. So when I ask, my answer to this question is that more data is helpful for some people at the individual level, but it's not the preference of other people. And unless we can, we think that that's a goal that we want to attain, it may possibly increase our health disparities, especially when we start thinking about nuanced decisions that really do maybe depend on data. So, thank you.
Okay, that was the round of introductions. So now we will see if we can get the game going. Close all that stuff down. So if you get your devices ready, please, then we will start up the game. And what will happen is that you will get a pin on the screen that you will need to enter to be part of the game as we play it. So that is our game pin. So 5773870. You got it? And then the app will ask you to select a name for yourself. And then you should, when you're recorded in the system, you should see your name pop up on the screen. So we'll just spend a couple of minutes doing that. And as I said, there will be very attractive prizes at the end of the quiz. I can personally guarantee that. And then we'll try to divide the time. So we will play the sequence of panelists in the reverse order. So we will start with Barbara, and then Louisa, and then with Ed and Quinn and myself at the end. And not to shortchange anybody, we will try to keep an eye on the time so that each of the sections will have more or less the same number of minutes. And for the questions, some of them may call for more discussions. We can dwell on a question for a longer time, but then we will have to move quicker through the remaining questions. You know the dynamics of this. All right, anyone who still hasn't registered who wants to do it? Otherwise, we will get going. So this is our warm-up question here. Are you ready? So I'll see if we can go in full screen mode. So this is Gary Larson's the 4 personality type. The glass is half full, half empty, the confused guy, and the guy who says, hey, I ordered a cheeseburger. So now you make your choice, and then it will count how many in the room have whatever answer. You have 4 seconds left. You need to be faster, guys. Not surprisingly, if you work in public health, you must be an optimist. So 10 in the audience felt that the glass was half full, and 3 were honest enough to say that they are the guy with the cheeseburger. I'm personally in that category, which may not surprise those in the audience who know me. So that's basically the dynamics of the game. And then we will turn to the real questions, the one that our panelists have defined. And again, it's the same dynamics. The question will come up, you commit yourself, you have 20 seconds to press the right bottom of the 3 or 4 possibilities, and then we will take some discussion once we see the distribution. All right? Let's run. There wasn't any points for this first question, so nobody is leading currently. So Barbara, these are your questions.
Okay, can I have a comment from somebody who said yes? Bob?
In my mind, that will make personalized medicine available to those who can afford it most.
Uh-huh.
And those least able to afford it will not get access to the same technology. So that will increase disparities.
Okay, anybody else on the yes side want to, back here?
I probably don't need a microphone.
Just shout.
So something similar, like the treatment options that are available to you depending on your class or your race or your geography. For example, I underwent physical therapy, and some of the treatment options that my physical therapist recommended for me, I don't think would be available in other areas.
Thank you. Anybody else want to answer yes?
I don't think it's any different from any medical technology that we have now or that we will have. If we don't, in the circumstances we currently operate within the United States, let's just pick the United States as one example, we're not going to see an equal distribution of the use of the technology.
Thank you. How about somebody who said no? Anybody want to take that side? Hanji?
I prefer no because unintended consequences is small probability. The small probability follows random process. Random process does not cause any disparity.
So you feel the decisions would be more objective, that the match would take the person out of the equation in a way? Yeah.
What's the definition of a disparity here, though?
Well, I'm using the definition that different groups would get different services at different rates. Okay, so would, for example, an expensive chemotherapy drug be equally available or offered to someone poor who's maybe on Medicaid or Medicare, or as to someone who has private insurance and is wealthy?
But just personalizing the medicine, so to speak, could lead to disparities, sort of appropriate disparities, that one group gets one thing and another group, turns out, outcomes are better with something different.
No,
So I think it's, in some sense, it could be hard to tell if you've got a disparity issue.
only if
racial
I guess only if that discrepancy led to negative outcomes.
I'll disagree with that. Yeah. I'll disagree with Dr. Sundik's interpretation by saying we have ample evidence in the early days of very complex HIV/AIDS treatments that low-income, low-literate people couldn't follow the instructions even though the treatments were effective. And that may happen with personalized medicine. The more complex it gets for the patient, the greater the difficulty those getting the same recommendations. It may create disparities between those who can do and follow recommendations from those who cannot follow those same recommendations.
Well, that's actually, we found that in our study of gastroenterologists who do colonoscopies. They didn't want to have to explain to low-income or low-education patients because it took too much time. It was just too hard.
Maybe
So-
you should use the mic, I think.
Yeah, that's right.
So they potentially they get shorter follow-up instructions and not as sure about where they should be going next.
So I want to ask a question related to that. So is that a problem? I mean, so would you not have the HIV therapy because some people can follow instruction and some not follow instruction? Or would you not do this precision medicine because some people will be able to benefit more from it than others?
Me
The
personally?
concern is that it's another barrier for those people who are not health literate.
I know, that's a concern, but my question is,
And
because
one
of that
size fits all,
concern,
that's
should
what
you
we
not
get.
do it?
In my
Because it
opinion,
is-
you should do it, but you have to be very aware of the unintended consequences of what we're doing and where we're going. That's kind of my point.
Let's see if Barbara's next question is less controversial. So all patients can learn to integrate findings from big data into their treatment decisions. That's the proposition. And we have the same possibilities, yes, no, or Lots of no's.
That surprises me, but in a good way, in a good way.
These are all softballs. When are you gonna give us something hard?
All right, who said no? I'm a nice person. You said no? Okay, tell me why.
Well, I think the ability to learn, all patients can learn. I think there's variability in abilities to learn. Of course, it would depend on how it's communicated and what a person's ability is to absorb and learn what is communicated. It wouldn't be any different for anything else, big data or anything else. There are differences in abilities to learn. Of course, it's very hard to come up with a scale that would rate that
Yeah.
across people. So
I think it's true. I think it's a
maybe it's a trick question.
No, I
it's a
think, well,
big
it
challenge
is, in a way
also
it
for the
is.
researchers, actually.
In a way it is, because I think it also includes preferences, like we were talking about, that's a low preference for some patients. Maybe they want to expend their energy other ways. It also includes emotion and anxiety, which can also make decision-making very hard. So I think it's not a trick question, but a complex one.
And let's try, that's the scoreboard, Pal, Jess, Ed. Let's try the case story. So Barbara also had a case story she would like you to read. A mother finds a lump on her child's upper arm. You need to read fast here and then answer. Would you wait and see if these tumor changes or tell the surgeon to schedule surgery right away or try to get a second opinion? Yeah, that one separated the men from the boys, didn't it? You had to read.
Separated the slow readers.
You had to read that quickly, didn't you? That would give a bit of a spread among the people leading the quiz.
Okay, so our big winner is get a second opinion.
I think that you didn't give us enough time to read the question.
I'm not sure we can go back.
Maybe it's an ability to learn on my part.
Yes, if you're a slow reader, you're out.
Yeah.
So somebody who did get to read this all the way, a comment? Most of you said you'd get a second opinion?
Okay, so to summarize the case, it was a woman who found something on her arm, turned out to be benign tumor, but there's a 1% chance that it could mutate or
It's her daughter's arm.
Oh, okay. That's what I got.
Yeah, that it could be.
Yeah, it was a 1% risk. Yeah.
So most of you would get.
The case was too complicated
It was,
relative to the time available. But that was the
that
trade-off.
actually happened to
A
me.
low risk of this turning malignant.
That actually happened to me, but it was about 20 years ago when the data were not collected, and I had to go to the journals, the epi journals, and try to figure it out myself. And about 1% was as close as I got. but we did wait and see. Minority answer.
Okay. All right, sorry about that one. That didn't work extremely well. There'll be an evaluation of the quiz at the end, by the way, so that's your chance to complain. Let's look at the scoreboard. Now, that really did it, huh? Jess and Barney. New number 2 here.
Well, what do you get high score for? That's what I don't know.
Being quick and taking the right question. So this is Louisa's. Are data objective? Yes, no, or hmm?
You mean based on what Barbara said was the right answer?
Yes.
Yes, that was her choice. It's the panelists that choose the right answer. So whether you agree with Barbara, that's the test.
I'm telling you,
There's no objective truth here. This is
that's a
science.
minority opinion.
What's the right answer? Yes?
No, the answer is no. That's the right answer.
According to that, the answer is,
Yeah, I picked that one, Lisa.
yeah.
Yeah, put down no.
Lisa's answer is no.
So no, so the question here is, you know, we talk about data as something that can help us decide in a somewhat objective way, taking out what we feel may be biases. And so that was my question, are they really objective? And I see that most people agree with me that they're not, because the interpretation is really what counts. So it's that step from going from numbers to action or to behavior. And in there, all the biases can get back in.
Yeah, even understanding what they mean, huh?
Right. And even the selection of data.
Yeah.
That would be my second.
Correct answer was miscoded.
Right.
It was, isn't that a
Yeah,
data?
That's the quiz master saying.
So
I'll take all the blame. Louisa is innocent in this. All right then. Is policy based on data?
Not anymore.
Yes, in many cases, no, very rarely, or yes, but data are often selected to support a certain view.
and someone who answered the majority answer, data are often selected to support a certain view. Can you comment on it? Who chose that answer? You did?
I chose it.
Okay.
My outside voice. No, I chose the yes, but data are often selected to support a certain view, because we see that going on right now just in current events. And so, you know, you can find, I think a pastor once said that even the devil can find scripture to support his views. And so anyone can find, if you look hard enough, can find some data to support a certain policy. It doesn't mean that they're giving the entire picture, though.
Yeah, it's complex, isn't it? And not all data would be in agreement. I actually agree with that.
So who answered yes in many cases?
That must be one of the glass half full people. An optimist.
I did, but it's just because I didn't see that yellow option.
You would have picked that.
A millimeter error.
But I do think that, in addition, I think policy is very closely linked to politics. And I think that
I think that leads into your third question, doesn't it? Leading the field? Should policy be based on data?
Comments? Those who, I would have.
I got that one right, Louisa. I wrote the answers, yeah.
Evaluation of the Head Start program indicated that it had any benefits. And the political decision was to fund it anyway, never anticipated. And the flaw was in the evaluation itself. But the design was faulty.
measurement error, there's no bias, data can be used to evaluate the policy given the two conditions. The data itself is a representative sample of the population. There's no measurement error.
There are challenges, isn't that right? I mean, I have a daughter who's a lawyer and who works in the Legislative Fiscal Bureau in the state of Wisconsin. Most of the politicians will not understand the data, and I'm saying this with due respect. And in many cases where we have data on two sides of a question, even the scientists will not agree. Huh? You think about the discussion about screening. How often should we screen? Who should we screen? So if I'm not trying to force this down. Your question is if data matter. I think we're all biased because we are convinced by data, and we like data, and we read data, and we understand data, we think. But outside of this community, it has much less impact than we would like to think. Huh? And I think we need to realize that and probably be better at communicating, being better at presenting, being better at being self-critical. Huh? I mean, trying to challenge your own hypothesis.
I agree with you. In that case, we need big data. We need data from different resources to evaluate the same policy.
Yeah.
So if the efficacy or effectiveness of policy can be confirmed by data collected from different resources, we have very high certainty to say there is effectiveness of the policy.
Yeah, it's an obligation.
There is a question over there.
I just wanted to say too that I selected the other one. Oh, sorry.
I thought it was loud enough.
I selected the yellow one because, even where the data are perfect, either, lack of bias or whatever, there are competing priorities in our society. Prefer another policy intervention, even in the individual liberty or equity.
Would be, I suppose, and so if you're trying to saving lives and the values of to protect other values, knowing that there's risk, it's very challenging to overcome deep-seated value after our argument.
But some of that is not produced. The data are still the data.
Yeah, I think my point is it's than others, and so
right.
you have to understand what you're trying to.
No, I think there's what data means. It's interesting that because the different points, the data are, if that means the actual were collected, there could have been other numbers that were collected, but then there's the analysis of it. I wonder, are we talking about studies, particular, studies that were done, groups, as opposed to the data per se, itself. So it's interesting in all of this. I think there is this kind of definitional question.
And it's about understanding the limitations to the data, isn't it? It's about understanding data quality and what the data really does say, even when they're there.
And the question that gave rise to the data.
I think there's an additional dimension to the question whether policy should be based on organizational process. It's not an individual decision. And at one point when funding three-letter agency, said what you need to understand is that in any organizational process wins or power wins, and most bureaucracies process wins. And so when you're saying it's a bureaucratic decision-making process, then things like governance and structure and sitting on the right committees and being in the right room when there's a discussion is often more important than having the truth.
Yes, and there are other more mandates than just data. I mean, something could be evidence-based but highly unfair, say, and most people would probably disagree to doing that.
You want to take one more?
Yeah, let's take one more. We're having too much fun here. we have a job to be done. Yeah. You wanted to say something?
When we are talking about data, data means that the collection of information. These informations are so many elements. So we are talking about data safely. You're basically looking at all those elements in the historical, you see, or those are basically data.
Yeah. And partly in what I'm going to say towards the end.
Well, then it's easy to do. So I have a question for you. With your slide in which you showed the survival curves for prostate cancer, do you think that people should make a decision based on that curve, on those curves? Because there's a lot that's left out of the curves.
Yes.
You know, for example, there's no starting points. You know, Gleason scores, for example.
Right.
Okay, so,
Yes.
but it's easy to put together, you know,
Yes.
or straightforward to put together
Yes.
something like that.
And it
And so
looks
it's a concern that, that policy can be based on something like that.
Yeah.
When in fact, data to me is like an artichoke, you know? Lots of layers.
Yeah. Sometimes
And they
not
taste
yet.
good,
Yeah,
too.
yeah, yeah. No, I agree with that, and I think it is, I mean, the big data collections now, I think, personally, I think it's a fantastic opportunity. I think we need to understand what we can learn from the data set. It's like understanding any other model. The data, in a way, is also a model. People feel that the data are reality, but in a way, they are a model of reality. They are numbers in a machine, in a chip somewhere in a computer. Huh? And we need to develop those analytical skills. Some of the traps is that it's easy to produce highly significant p-values for something that looks like evidence. Huh? That particular paper with the prostate wait and see versus active treatment, that has been cited again and again. The substance selection bias is hardly being cited except by bias that wants to be fooled. Huh? And this is it, because it will prolong your expected life with so and so many years. And that's where the challenge comes, also for the consumers. How do you distinguish between the plastic and the leather? How do we educate people so that they can read a curve like that and say, hey, wait a minute, is this actually corrected for staging? Is it corrected for Gleason score? Is it corrected for PSA at baseline? Yes, the chairman just, we are moving on to you, Ed. Catherine is...
Wish I could remember the questions. Yeah?
Catherine is doing well. How do national data inform the community about its health status? And these are the options. Not much. Health is the same across the country, so national data help, or they give an indicator, they aren't precise. So, what do you think, Ed?
I think the yellow option is correct. I think they're useful, and that interpreted. And I think in a lot of the gaps we're talking about, built by some sort of market mechanism that either creates professionals who do that, or companies that help people make these complex kinds of decisions, including the personalized medicine decisions. Right, like Louisa said, like genetic counselors, which is.
Like clinical epidemiology.
So I would second your comment about interpretation. You know, much like you're talking about healthy people, in taking a look at data at the local level, oftentimes the cell size was small, or in fact there were temporal things that were happening that unless you looked at it over time, the wrong time. So.
All right. Let's see. Oh, not great for Catherine. Are there community-specific data sources? That's still one of Ed's questions. My county collects very little information. I've never asked about my health. I've heard that there are, but we live in a big county. Sure, the government is probably prying into all our lives. I have to say, Ed did come up with these possible answers.
You're not supposed to do that. No.
All right. So, yellow or green?
You know, you cut something out from my answer.
I did.
Yes,
because
and
of
my
the
answer included that the government and others are listening to us through Facebook and Alexa. Yeah.
That was the green.
No.
When you have an
I
Alexa,
apologize for that, because of the
Well,
format of the
an Alexa, you'll find out that that's very true. I think that that we live in a big county. For example, Montgomery County is very diverse in many, many different ways. And if you wander around the restaurant capital of the world in Bethesda, it looks one way. And if you're out, you know, up by the mountains or whatever, it looks very, very different. And so you have to question how good the county data sources are when you have that kind of diversity.
Yeah.
But again, that's a challenge to public health in the county.
All right. Where do I find the local communities, data manipulators, analysts, interpreters, guides, and natives? And these are all our options here. I haven't the slightest idea. It's an attractive option, of course. Local colleges. And that was also your preferred option, wasn't it, Ed?
Yeah.
So that
Right,
is
but I'd like to see us doing more of that. I think this is something that could be an initiative for schools of public health, looking, and Bob, to corral these resources, okay, and not necessarily to make them absolute experts in public health, but there's certainly analytic tools that are available elsewhere in the collegiate community, okay, and a technical community that could be applied. But it's a matter of trying to find the right incentives to get these people involved.
Yeah, that's a great mission.
Shouldn't the community be involved in interpreting their own data? So that rather than necessarily faculty, community members, I'm thinking like in healthcare, we use the promotoras, lay community workers or something like that. Shouldn't they be involved in interpreting data for their own community?
Yes, I completely agree that they should be. But if what you've got is raw data and you want to put it in some form where a county council, for example, can understand what's going on, then I think you need some technical expertise on the data side to put it together, particularly in how to display it and how to get people to understand what's not there that they should be trying to take account of.
All right, we need a sprint here. Let's see. So this is one of Ed's questions still. How crucial is data quality, and how do I, as a community resident, assess data quality? Data comes from lots of people. Quality need not be perfect. That was Ed's preferred option, and roughly half of you selected that one. And then, because we are slipping a little bit, what data is crucial to the community, and how do residents use it to improve their well-being? And these are the options. Disparity data is a clue to more effective steps to better health. Comparing one's own regimen to recommendations is the first step, or above average health issues in community is an indicator that not all is well. All right. So here its preferred option was...
Yeah, mine was actually the third one, the yellow.
Yeah, it was, and that is marked as a correct
Yeah.
answer. We'll see what that did to everybody, but I'm sorry we are running out of time, so Jess is doing...
Yell at me later.
So, Quinn, what are the barriers to public health engagement with big data? Is it infrastructure, or is it analytic skills, or is it privacy concerns? What are the barriers to...
Really no right answer.
answers. It's more of a polling for what is your experience.
Analytic skills.
Yeah, so I chose like big data analytic skills because we do, like, just for my experience with the data, that seems to be, as public health professionals, we're trained in certain skill set. Once we get into big data, we have to learn entirely different skill set, and it's very difficult. It's, the skill set is more computer science, engineering, and so that is a large barrier.
So some of these black box papers are not easy even to read and criticize, huh? Because often the structural resolution in a large data set tempts people to do very fancy modeling. And statistically speaking, that makes some sense, but it doesn't make it easy and transparent to criticize the model after the fact, because there are so many other possible models that you could have developed in the same data set. So I think that is a challenge. Yeah, N7 and yes. What ethical concerns present themselves that are specific to big data? Is it that you cannot get informed consent, that data ownership is often unclear, or that extended network social connection data may not be protected?
I think this is almost like equally, when I was like, I forgot what I wrote as my answer. All of these are very critical. Informed consent, for instance, the big data sets that I worked with, there's no informed consent. Twitter, the API, if your tweets are publicly available, Twitter will sell your tweets, or the API is there and people can download a random 1% sample of the tweets. Informed consent doesn't work normally as it does in, for instance, health surveys or randomized trials. For data ownership, it's small for these large data sets. If, for instance, Facebook, the company has it, who owns it, you produce the data, but do they can freely perhaps disperse it? And then, there's like the issue of you have your data, but then what if your data mentions other people's data? So that gets into the weeds of those ethical concerns for not only for yourself, but then your extended network.
There are concerns about combining data from many different sources to the extent that you can do that, where certainly you can do things that were not sort of implicit when people accepted to be registered.
What are people's experiences with like the ethical aspects of big data? What have you found to be problematic when you're working with kind of larger data sets?
Well, I would say that if you try, you can always identify the individuals.
Yeah.
I think that's a problem.
Yes, and with the larger the data set, the more variables you have, so the more clues you have to identify the person.
If you analyze data from Seer Medicare, they expect you to submit the paper for review by them before you submit it to a journal.
Yes.
And they will delete all cells from tables that have less than 10 people in the cell.
Yeah, but you can go back to other claims data and look at people who had the same procedure or same diagnosis on the same day and then figure out
Sure, who
things
they are, yeah. All right. What analytic problems can be solved with big data? Oh, that was very, very quick. I'm not sure I can go back, actually.
Oh, okay.
That wasn't deliberate. So.
Oh, yes. So this is kind of like, so what are some issues that we can solve with big data? And I think for this one, I put more precise estimates.
Yeah.
So like the more data we have, we're going to get very precise, like in small confidence intervals variance. So we know the answer, because in the past when we had small samples, we had an estimate, but the variability was so wide that we were unsure where the data is. But when you have a lot of data, you're going to get more precision. And you need to also understand other things like heterogeneity, local patterns, because sometimes we can't understand local patterns if we only have national data. But with big data sets, you can start drilling down and learn.
Okay, so we need to wrap it up. I believe we have 4 questions left. We will just run through them because we need to find a winner. What issues arise? That's still one of yours, Quinn, isn't it? Potentially less control, estimates of association are more precise, uncertain how computer models arrive at answers. Please answer it, and then we will move on fairly quickly. All right, less control over quality of data, and that was also Quinn's preferred answer. Okay, so we will do these very quickly. That was actually, believe it or not, why I put myself at the end. So according to the National Comprehensive Clinical Network, what proportion of all cancer procedures are supported by level 1 evidence? Is it more than 70%, 40%, 15%, or 5%? Sorry?
Is level 1 the best type of evidence?
Yes, that's the highest. Consensus and evidence from randomized trials. Sorry. The correct answer is 5%. And there's an Institute of Medicine report estimating that in all fields of medicine, it's around 4%. So cancer is doing relatively well, if you like. FDA's Mini-Sentinel database contains drug safety data with more than 300 million person years, 110 million person years, 30 million person years, or 10 million person years. So this is a distributed database, a network of databases. How many unique individual data do they hold in that data collection? 300 million is correct. That's a high number, huh? Pretty good. Missing values in big data sets are, and here are the options, a fact of reality, they're always going to be there, depends on whether they're missing at random, less of an issue because of the large sample size, or will likely introduce bias due to mass significance. That's a good even distribution. Yeah, it depends on whether they are missing at random. Often they are not. So the data that are missing are informative, so to speak. Gee, N7, a new leader. Current large registries are useful for comparing, and that's our last question, the effectiveness of drugs after marketing, management of rare disease presentations, how they are managed, patient-reported outcomes, or all of the above. I love you. So you believe they're good for everything. My preferred answers was that you can use to actually document how very rare presentations are managed. Say, if you have breast cancer with an unknown primary tumor, what are people really undergoing in terms of therapy? Whereas all the others, there are basically no patient-reported outcomes in most registries, and effectiveness of drugs after marketing is another business. So, you made it. So N7, and I did bring the prizes as I promised you. They are somewhere in my bag.
Oh, I thought it was the backpack.
No. I won't give that away. Let's see. This is the third prize. They have different. This is the second prize. So we need N7. You are the winner. You are the best. Is it you?
Good job.
Come up here. Well done. I don't know if you can write it in your CV, but this is a gift card. And then we would like to know, yes, unfortunately, it didn't make it all to the end. That's you? And then we have Ed.
I get nothing.
Well done. All right, thanks a lot. And please
Can you ask the winners to introduce themselves, say who they are?
Yes, that's a good idea. Will you briefly introduce who you are and why you know so much about big data?
My name is Samasha Fernando. I'm a Master's of Public Health student at the University of Maryland School of Medicine.
Well done.
I guess I know so much because of our course group.
Absolutely. Right answer.
Extra credit.
You will most likely succeed.
some years ago, also at the University of Maryland as an undergraduate, and then at CDC more at the director's office and at the Development Foundation.
All right. Very good, and thanks for playing along. Thanks for being a good audience. It was an experiment. Any kind of critique or feedback is more than welcome. We may never do it again, or maybe we will do it again. But, we will listen to any kind of advice. And I'm sorry we ran out of time, predictably so.
Thank you very much to the panel, and we will move into
Yes, and you should all go to the
atrium.
atrium, please, because there we will have the concluding remarks.